Welcome back to Diabetic Foot Files. I had to take a little break from the royal wound session because the way my brain works is just I just go with whatever I'm passionate about. So today's episode, before we name brands, codes, products, we need to name the enemy. And the enemy in diabetic foot ulcers is not just skin loss, it's pretty much biological paralysis. So, skin substitute. I know I've been through it before, but it was just like scratch surface level. But we're going to go more in depth about skin substitutes, like skin graft, where we're not just created. Skin substitutes were not created just to cover wounds. They are created because diabetic foot ulcers, they forget how to heal. So if you understand why a wound is stalled, you will never know which graph belongs on it. Okay. So we're going to go about the science, the basics again about, healing and why you wouldn't possibly need a skin substitute. So the gold standard, the normal healing phases that we all know. There's four phases, okay? To understand skin substitutes, so like skin grafts, right? We first must understand what we are trying to replace or what stage we're trying to restart, okay? So the four stages of normal wound healing. First stage is hemostasis. That happens within minutes to hours of skin breakdown, right? So the platelet like clumps up together, aggregates together, the fibrin clot formation. There is a release of PDGF and there's a release of TGF beta and fibrin scaffolding. The purpose of this phase is to create a provisional matrix and to stop bleeding. The inflammatory phase, which takes days, right? Which is like days after initial injury, right? This is where the neutrophils, they move to now, they give the task to the macrophages. The neutrophils turn into like go to macrophages. And the macrophages one macrophages dominate early. And this causes a controlled cytokine release. Cytokines are IL-1, IL-1, TNF alpha, and IL-6. Okay. The purpose of this is debridement by immune cells and bacterial control. Inflammation is necessary, but it must be resolved. Okay. And remember, that's the stage that a lot of diabetic ulcers are stalled in. That's the phase. Third phase, proliferation phase. Okay. So that takes days and weeks. The fibroblast migrates, right? There's a migration of the fibroblast. There is collagen deposition of collagen type 3. There's angiogenesis, which is the formation of blood vessels, and that through VEG, FEGF. I call it VEG-F, VEG driven, okay? And keratinocytes migration. So those are like with the skin, right? And the purpose of this phase is to build tissue, restore perfusion, and resurface the skin. Last stage is the remodeling, which takes weeks to months, probably even a year, in my opinion. So, in the remodeling phase of wound healing, collagen type 3 moves to collagen and gets replaced with collagen type 1, which is the more stronger one. And there's capillary pruning and there is increase in the tensile strength. So, the purpose of this phase is to make a durable closure. Okay? So the key principle to remember is healing is not linear, it is conditional. And if any of these phases stall, the wound fails. So what goes wrong in a diabetic foot ulcer? Okay? Diabetic foot wounds do not just heal slowly. They usually exist in a permanent inflammatory arrest state. Okay? And why is that? There is first a protease chaos. There is an imbalance between MMPs and TIM, which is TIMP balance, okay? So in a normal skin wound, right, the MMPs break down the damaged extracellular matrix, and the TIMPs regulate the MMP's activity. But in a diabetic ulcer or diabetic wound, the MMPs would, break down damaged extracellular matrix is increased. There's a higher level of MMPs. And the thing that regulates the MMPs, they're downregulated. There's very less of it. So the extracellular matrix is destroyed faster than it can be built. And what is the result of that? The collagen scaffold collapses, growth factors are degraded, and cells have nowhere to migrate. So you cannot build a house on a scaffold that dissolves every 24 hours. Fibroblast silence, okay? So in diabetic ulcers, the fibroblasts are much fewer, move slower, produce weaker collagen, and respond poorly to growth factors. On the molecular drivers of this, causing it to not be so functional, is the hyperglycemia, the oxidative stress, and the advanced glycation end products. And what is the result of that? Poor granulation, weak wound beds, and fragile closures. Three, the macrophage lock-in, the M1 dominance. Okay, so normal wounds, they have this transition from macrophage 1 to macrophage 2, which typically occurs. Okay, but in diabetic foot ulcers, macrophage 1 phase, that type of macrophages persist, and macrophage 2, which are reparative macrophages, they're suppressed. Okay, so we need M1 to move to M2, but in diabetic foot ulcers, the M1 persists. Okay, like they really don't want to pass on the torch to M2, which are the reparative macrophages. Those ones are suppressed. Like they kind of like, you don't want to have a successor, and the result of that is chronic inflammation and failure for the wound to enter into the proliferative phase, and the wound is stuck in this fight mode and never switches to this rebuild mode. Then angiogenic failure. The I call it VEGF, okay? Just look it up. VEGF. Okay, signaling is impaired due to the endothelial dysfunction, the nitric oxide depletion, which plays a huge role in that, and the microvascular disease in diabetics, okay? And with the result of that is hypoxia, poor nutrients delivery, and failure of epithelial migration. And five, stem cell dysfunction. So there's a reduced mobilization of something called endothelial progenitor cells, okay? And the bone marrow signaling is impaired, and that results into a limited regeneration capacity, which a lot of diabetic wounds have. So when standard of care fails, so like what is standard of care for a diabetic ulcer? Debridement, offloading, moist wound healing environment, moist like the balance, okay? And infection control, right? These are all necessary, but often insufficient. And why is that? Because standard care, you clean the wound, you protect the wound, but it does not biologically reboot the wound. And standard care maintains, but skin substitutes actually intervene. So, what do skin substitutes, what are they designed to do? So, just like an amputation, like you need a prosthetic, right? To help you walk, like from a below the knee amputation, right? A skin substitute is like a biological prosthetic. They are designed to replace the missing instructions, not just the missing skin. Okay? So, what are the core biological functions of a skin substitute? Biggest thing is extracellular matrix replacement. They are able to supply the collagen, the elastin, and the aminoglycans, okay? And this causes reduced protease dominance, which causes that breakdown of extracellular matrix, right? It stabilizes the wound bed and allows the cells to attach. Next, the substitute causes cytokine rebalancing. So many grafts they help suppress that TNF alpha, reduce the IL-1, and encourages the macrophage 1 to move to macrophage 2 shift. Okay. And they quiet the inflammatory noise so that healing signals can be heard. Okay. Then growth factor signaling. Depending on the type, they may provide this PDGF, VEGF, FGF, which is like fibroblast, and TGF beta. Okay. And what do these growth factors, these signaling growth factors do? They stimulate the fibroblasts, which we need. We need promotion of the angiogenesis and acceleration of the epithelial migration. And then the cellular communication. Okay. Cellular grafts act via paracrine, which is side by side, right? Signaling. They do not permanently end graft, okay? The function is as a biological messenger. So they teach the wound how to heal and then they disappear. And then mechanical and structural support, it's very important for like exposed tendon, exposed bone, or post-surgical wounds, okay? So here's another critical part when it comes to using skin substitute. Why would a skin substitute fail? Okay, so we have to think about the critical thinking of this aspect. Skin substitutes fail when clinicians apply them to an infected wound, ignore the ischemia, that's why you need vascular, skip the debridement, apply over apply it without reassessment, and then just use them as a revenue tool instead of a biological tool, okay? So you have to think about all this. And a graft cannot override hypoxia, cannot override necrosis, and cannot override gravity. So, like, if there's no blood flow, like if his, like we say, ischemia, if there's no removal of any dead, devitalized necrotic tissue, if there's no offloading, that it's just gonna come off, okay? So just keep that in mind. So, biological reasons for failure of a skin substitute, the protease degrade the graft before it can integrate into the skin. Inflammatory cytokines actually kill the delivered cells, okay, of the skin substitute. Poor perfusion starves the matrix of the skin substitute, and repetitive trauma disrupts the neo tissue, the new tissue that's trying to form. So, this is part one of skin substitutes. So the master principle is skin substitutes are not treatment for wounds. They are treatments for failed wound biology. So keep that in mind. So you must match the skin graft to the pathophysiology of the wound, not just the wound size. And in part two, I am not a paid partnership with any grafting or whatever, but it's good for people to know so that they can be able to provide for their patients. Okay. So part two, we're gonna name like pretty much majority or like the common wound grafts, okay, and decide which one belongs on which, okay? So if you don't understand the biology before this episode, I'm hoping that you can, and then we can make everybody accountable. And we're gonna do part two next, okay? Of skin substitutes. And this is Diabetic Foot Files. This is Dr. G, where toes tell the truth and where biology always wins. And take care of your feet because we take care of you. And stay tuned for part two.